All right, there we go. So, because you may have already noticed, but clearly the speaker uniform for the males today is blue shirt, tan pants. The only way you can tell Dr. Pottinger and I apart is the tie. And I'm very tempted, because he did such a great job of getting rid of his tie, to just dump mine right here, right now, too. But then you would be totally confused as to which one of us was which. I understand. I also want to thank him, because I realized he just basically knocked out my talk. So I'm going to go back there and sit down and just kind of chill in the back and hydrate so I don't get a UTI. But basically, we're going to talk a lot of antibiotic stewardship this morning, and I've got more slides than I wanted, and so Dr. Pottinger crushed the UTI section, so I can move a little bit more quickly through that, because we've talked about a lot of that already. So there has been an absolute ton going on in this space over the last couple years. And very much, as you've already heard this morning, it is so nice to be back and so nice to see you all live. As you know, I think we're all sick of talking about nothing but COVID over the last few years. So it's great to be back and doing this with you again. So disclosures here on the slide up in front of you. You can see I've got a couple there, but I promise to be on my best behavior this morning. The objectives with regards to what we're going to talk about is Joint Commission's at it again, okay? And Joint Commission is going to stay at it. And I think this is something that we all need to recognize across not just our inpatient settings, but also our ambulatory care settings, that antibiotic stewardship is something that the regulatory bodies are going to want to see, they're going to be interested in, they're going to want to know what your institution is doing. And as I will show you, as we kind of move along here, the next round with the Joint Commission is going to talk about what that screensaver is. I have no idea what that is. It's really pretty. There we go. Okay, it's back. But the Joint Commission is going to be really interested in kind of how you're documenting stuff. And so again, I think you're just going to see these requirements get more and more stringent, because, you know, as we've talked about and as Dr. Pottinger showed you in a couple of his slides already, the resistance rates just continue to move. And so I think this is really kind of one of the ways that we're going to have to continue to really kind of stay involved to try to keep those under control as best we can. We also, I think, were reminded of some very painful lessons during COVID in the antibiotic stewardship space. And so I want to talk about kind of what we saw and what we learned and what we should take away from kind of our COVID experience with antibiotic stewardship over the last few years. We'll then also talk a little bit about diabetic foot, because the last couple times I was here doing this presentation with you all, diabetic foot is always an issue that comes up in the Q&A section. And so one of the things that I did was really try to include a couple slides that are up to date into this space about ways that you can be thinking about antibiotic stewardship in those patients. And then finally, I really want to leave with a plea as we head back into respiratory season for vaccines. I know that it's been like nonstop vaccine warfare, and that's a completely separate talk, but I think that really recognizing that increasingly the data shows us that influenza vaccines are an absolutely essential antibiotic stewardship tool. Why? Because if you're vaccinated, you don't get sick, and if you don't get sick, you don't end up on antibiotics. And so I think our influenza vaccines, our pneumococcal vaccines, and yes, the new COVID boosters are all going to be valuable antibiotic stewardship tools, and so we'll talk about that a little bit. So this remains one of my favorite quotes in the infectious disease space, despite the fact that Lou Rice now said it 15 years ago, all right? And that was back when ICAC was still the best ID meeting in the world. Don't talk to me about ICAC going away, because I still think it was the best ID meeting ever, and it's gone now, and I'm still bitter and angry about it. But the quote is absolutely spot on. One of the things that I really want to drive home today with regards to this, and Dr. Pottinger touched on this at the end of his presentation, duration, 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 duration. Okay? I think we're getting better at recognizing the downsides of antibiotics. We're getting better at talking to our patients about the risks associated with antibiotics. What we are not getting better at is using the shortest duration of antibiotics possible. There are still way too many of us out there, okay? I round every day with a bunch of infectious disease docs at OHSU. I still, and I love these folks, and they're total antibiotic stewards. They support me all the time. They still default to longer durations than they need to. Even the ID docs in academic centers struggle with this. Our fellows, it's like you give them a duration of 7 to 10 as an option, and I'll be danged if they don't pick 10 every single time. I'm to the point now where I'm like 7, so just knock it off. We're not going 10. Fight the urge to go 10. Put the 10 down and back away slowly. We're going 7. It's 7 to 10. Everything's fine. Go 7. So, I think these durations are an area where we need to continue to work. And for those of you who transition patients from inpatient to outpatient, that is not, I repeat, not an invitation to restart another course of antibiotics when you send someone home. That is a huge mistake that is all over the literature right now and a huge problem, and I think really is an area of emphasis for antibiotic stewardship that you're gonna see coming over the next few years. What has the Joint Commission been up to? This is what the Joint Commission is up to for your inpatient settings starting in January 2023. This was published in June of this year. These are the new updated standards that they are going to look at when they show up to accredit your institution. These are going to be the questions they want to talk to your leadership and your antibiotic stewardship program about, and they will drag the providers in and be like, how do you all do some of these things? There's a lot of new updates here. There are actually 12 new or modified requirements. And I think the thing that really jumps off the page at me is something that we struggle with. Notice right here, sub-bullet 1, under a bunch 12 new modified requirements, information technology support. Dr. Pottinger touched on this. I'm going to hammer it. One of the biggest problems in medicine right now in antibiotic stewardship is you don't know your local resistance rates, one, okay? The other thing, too, is that antibiotic stewardship and providers really struggle to get their hands on real-time data that's local, okay? We fight with this and, basically trying to get IT support to help us generate data out of Epic. Epic is, how many of you in here use Epic routinely? Okay, good. So are you like me when you're driving on the highway and someone cuts you off, instead of using, maybe a more normal 4-letter word at that individual, you now scream Epic at those people? Epic has become a 4-letter word for me that I use when I'm really mad. I'm like, oh, epic that, because Epic is good in a lot of ways, but trying to get data out of that bleeping thing, is just absolutely a nightmare. And so I think this is going to be a thing for a lot of institutions. As increasingly as Joint Commission starts to ask about this, people are going to realize how hard it is to get at some of this data. And your information technology groups are going to have to step up and really kind of help us get at some of this data. The other thing, too, is think about how you're documenting your stewardship activities right now in your institution. A lot of places can say that they're doing things, they can point to programs, but documentation is kind of sparse. Do you see notes from your stewardship team in the charts? Do you ever see reports from your stewardship teams at your meetings? This is really going to kind of have to, I think, become more and more talked about and more routine, because it's not happening, I think, nearly enough to keep the Joint Commission happy right now. I think the other thing down here that is going to be really interesting is that they are actually calling for you to be able to show them that you've implemented guidelines in your institution for optimal management of some of these common disease states, but then you've got to show them how you're making sure that those guidelines are actually being used. This is something that we really struggle with. How do we prove that all this work we've done is actually being used by you all, the frontline providers in our institution? So it's like, oy. So I think there's going to be a lot of moving pieces in this space. And a lot of us who've been comfortable, oh, we're doing a good job with stewardship. We're doing a good job. These requirements are going to, I think, really kind of ratchet the heat up a little bit, and we're going to have to think a little bit more about how to kind of improve our game in the stewardship space. So what is antibiotic stewardship? And I think ultimately what this is boiled down to at the end of the day is it the right drug at the right dose for the right duration? Okay, and as Dr. Pottinger talked about, and I will talk about a little bit with asymptomatic bacteria, the right drug, a lot of times, is no drug. Okay, so it's not, again, a situation where we've got one of our ID attendings at OHSU, Dr. John Towns. He basically loves to talk about antibiotics, and we talk about covering people with antibiotics. He's like, covering. That's like you're laying down under a warm, fuzzy blanket. You're next to the fireplace. You've got your hot chocolate. We're covering. It's, it's warm. It's comfortable. It's comforting. It leads you to a wrong mental picture with antibiotics. His argument is, and I think this makes a lot of sense, we need to refer to it as antibacterial chemotherapy. Because again, you talked about, or you heard from Dr. Pottinger, what this basically does to the microbiota. You treat that sinusitis, you wipe out all the normal flora in every normal spot. This is chemotherapy. We know that microbiota dysfunction causes a lot of problems. These drugs are not to be underestimated with regards to side effects. Remember, the #1 healthcare-associated infection in the United States is C. diff. Guys, you can get C. diff for other reasons besides antibiotics, but it is almost always antibiotics. And that is what we do to these patients with antibiotics, all right? So I think it's important to recognize that a lot of times the right drug is no drug. And asymptomatic bacteria is a great example of that, and COVID was an absolutely phenomenal example of that, and I'm going to show you some data in that space. Why are we concerned about antibiotic stewardship, okay? Because unlike Lipitor, right? Have you ever driven by, I need somebody who lives around here. Somebody who lives around here who likes donuts. Anybody who lives around here like donuts? Sir, what is your favorite donut establishment in this town? We have a Krispy Kreme addict in the back of the room. I can certainly sympathize with that addiction. But, sir, I would bet you have never driven by, and I know I have never driven by, a Krispy Kreme and said, that is where the Lipitor-resistant cholesterol lives. Therefore, I will not go get donuts there because the cholesterol there is Lipitor resistant, and I need to make sure that my Lipitor keeps working, right? Please, infectious diseases is the only space where when we use our frontline therapies, we basically compromise them down the road. Dr. Pottinger showed you what happens to the microbiota, but also remember, not only do you wipe that microbiota out, but what's left is now been trained. It's looked at what you're using. It's going, yeah, that's ciprofloxacin. That's clever. I see you. Watch me mutate my DNA gyrase, okay? And so, you don't see cholesterol do this. And so again, I think this is the only class of drugs where when we do it, the target basically sits out there and mutates to get around them. So again, stewardship is absolutely critical. And you see this in this 2020 document from the World Health Organization. The World Health Organization says at the bottom of the slide, right there, overall, the clinical pipeline of antibiotic development basically is insufficient to tackle the challenge of increasing resistance and spread of resistant organisms. It is now estimated yet again late last year that basically increased mortality due to resistant infections will overtake, wait for it, cancer deaths by 2050, okay? How many new drugs have there been for cancer? Roughly 5 in the time I've been standing up here talking. Okay, that's how fast we seem to get new cancer drugs these days. But again, the antibiotic pipeline is an absolute mess right now, and so protecting and preserving what we have is absolutely critical. Okay, there we go. The bugs that we are most worried about, Acinetobacter, Pseudomonas, Enterobacteriaceae, E. coli. ESBL producing E. coli, third generation cephalosporin resistant E. coli, basically now pushing 10 to 20% in places in the United States. If you go to India, that number for Klebsiella and E. coli, for Klebsiella, it's now in excess of 80%. In E. coli, it's in excess of 50%. All those bugs are is a plane ride away. We basically had a New Delhi metallo-beta-lactamase producer in our unit from Vietnam 2 weeks ago. They're a plane ride away, okay? And so you see that antibiotic use anywhere impacts resistance everywhere. Next slide. Nope, come on. Okay, so let's talk about the right drug a little bit. What did we learn from COVID? Well, one, hopefully we learned that, again, antibiotics don't work for viral infections, okay? That's point one. Point two, we also saw that a lot of our bad habits reemerged. And I think you can certainly understand why a lot of our bad habits reemerged during COVID. When you are presented with an unknown infectious agent that results in an unknown clinical scenario that is really being reported as having a high death rate out of the gate, it understandably created a situation where clinicians were concerned, clinicians were seeing people die, clinicians were seeing people on ventilators progressing to basically ventilator-associated pneumonia. And I think there was a lot of concern early on that we would see very similar superinfections such as Staph aureus and Streptococcus pneumoniae to what we saw with, or see with influenza sometimes. And what all of that led to is all of this, okay? Basically, you can see that one, it appears infection control broke down a little bit during COVID, but two, that also all of this antibiotic use, all of this ICU time resulted in a lot of reemergence of a lot of kind of older problems that we thought maybe we were doing better with. Carbapenem-resistant Acinetobacter is typically an antibiotic use and infection control problem. And you can see that it reemerged by roughly 78% nationally during COVID. And I think that says a lot about some of the challenges that we really faced during this time. The other thing too, and I think this is again a really important point, diagnostic uncertainty far too often creates antibiotic use. When clinicians don't know, clinicians will go to antibiotics when they're not sure. And I think, again, this is why with all of these new rapid diagnostics, it's so important that we teach you all how to interpret them, that we understand on the stewardship side how to interpret them, because if you don't believe a result, if you have a positive flu A in a hospitalized patient and that person is still on ceftriaxone, what's the ceftriaxone doing? It's not killing the flu, right? But again, look at what we saw here. Look at bullet 3 at the bottom of this slide. 80% of hospitalized COVID patients received an antibiotic. 80, okay? Now, just double checking, COVID's a virus, right? Right? So, I mean, again, you know that basically antibacterials did nothing there, and half of these patients received ceftriaxone. So again, really, I think what you're seeing there is that inability to distinguish viral community-acquired pneumonia from bacterial community-acquired pneumonia. So again, I think this is a place where we need to continue to really work on this, but we also need to remember, and we also need to recognize that viruses are more than capable of causing community-acquired pneumonia that requires hospitalization. I think COVID teaches us this again, and I think influenza teaches us this every darn year, okay? So again, I think it's really important that we remember that viruses are more than capable of causing community-acquired pneumonias that are bad enough to require hospitalization. All right, let's switch from kind of the respiratory tract to where Dr. Pottinger was living. And I think he showed you a slide that was extremely similar to this. This is a paper that was published in Clinical Infectious Diseases last year by Keith Kay and group. And basically what I want you to note here is this line across the top of the slide up there, and the pointer's a little bit faint, but yeah, that's better than 25%. Okay, that's better than 25% resistance for trimethoprim sulfa. Now, a little bit of different data, and I think Dr. Pottinger put up a slide from Tom Lodise and OFID in 2022 that basically showed nitrofurantoin resistance rates being higher than 15%, if I recall his slide correctly. That is an important slide because it's important for you to remember that that was complicated UTI, because what I'm going to show you here is notice how low nitrofurantoin is on this slide. Okay, nitro, 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 nitro. Did I mention nitro? Okay, and I think that is really, guys, I am really struggling with this slide advancer. Am I doing something wrong? Do I need to be pointing back there at you guys, or just point it up? Okay, all right. So I think one of the big things for cystitis, especially for uncomplicated cystitis, we are not talking pyelonephritis here, right? Because remember your pharmacology 101. When you take nitrofurantoin dumps in, you take it, it gets absorbed, it runs out into the bloodstream, and it dives immediately into your bladder. I mean, immediately. It does not hang out in the kidney tissue. It does not hang out in the blood. So this is not your pyelonephritis drug. But what this is your cystitis drug, your uncomplicated UTI drug. And notice that at OHSU, our E. coli's are still 98% susceptible to nitrofurantoin. Let me repeat that, 98% susceptible to nitrofurantoin. And this comes back to a point that Dr. Pottinger made. National data is a disservice to you all locally. This is much more what you would expect to see locally. There is something very interesting about the Pacific Northwest. I am convinced that resistant bacteria do not like the combination of legal marijuana, cool, damp weather, and good IPA. Because if you basically have those three, you don't seem to have a lot of resistant bacteria, because if you look, the Northwest is actually one of the areas that has some of the lowest resistance rates. I also think that's because, well, you know, if you look at antibiotic use heat maps, we tend to use less antibiotics out here in the West for some reason than other parts of the country. So excellent job in that point. We need to keep moving in that direction with regards to durations. But I think for uncomplicated cystitis, at least based off our data in Portland, nitrofurantoin is extremely reasonable. And I love Dr. Pottinger's number needed to treat point, that trimethoprim sulfa is probably extremely reasonable in young female, no antibiotic exposure recently, you know, first UTI. I think trimethoprim sulfa makes a lot of sense there still as well. Okay, there we go. This, Dr. Pottinger mentions this. This is the black box for quinolones. If you need to fall asleep, read this thing. It's extremely long and it's extremely boring, but the point I'm trying to make here is there are a lot of reasons to put the Cipro and Levo down and back away slowly, okay? We should not be using fluoroquinolones as frontline therapy for uncomplicated cystitis at this point. They are good pyelonephritis drugs, as Dr. Pottinger said, but remember that up to 20% of your E. coli's are now resistant to these organisms. We're running about 10 to 15% of ours being resistant at OHSU, and if you look, what you'll see is a lot of this comes from people who've gotten quinolone previously or have recurrent UTIs. I think those are high-risk groups for a lot of quinolone resistance in your E. coli. The other thing I want to talk about from a right drug standpoint, in skin and soft tissue infections, there is a lot of resistance to clindamycin in Staph aureus and beta hemolytic streptococci. Most providers don't recognize that there are a lot of problems with group A, group B, group C, streptococci, and resistance to clindamycin. We are getting a lot of phone calls about cellulitis and skin and soft tissue infections that are not responding to clindamycin. I think it's this, okay? There's a lot of beta strep resistance out there that's poorly recognized. That's point one. Point two, also recognize that group B is in boy, strep, is a huge, huge player in diabetic skin and soft tissue infections. They are almost always resistant to doxycycline, which is what we're seeing a lot of folks in the community using for skin and soft tissue infections. So remember, Clinda and Doxy, there are some real challenges with beta hemolytic streptococci out there in community. And remember that amoxicillin is still the absolute bomb for beta hemolytic streptococci in skin and soft tissue infections. Okay. All right, so let's also talk a little bit about dosing. I am a huge amoxicillin junkie, okay? I think amoxicillin, and it may just be from the fact that I had a lot of ear infections as a kid, and I loved the pink liquid because I always felt better the next day, and you know, it was in the fridge, and I just thought it was cool looking. But our poor ID fellows, they're like, no, Jim, we can't use amoxicillin for this, leave us alone, right? I'm always pushing for oral amoxicillin in a lot of settings. One of the things a couple points that I want to make for this is that how many of you are routinely giving BID or twice a day amoxicillin clavulanic acid? And okay, I see some hands going up. Please stop, okay? If you look at that literature, first and foremost, remember that amoxicillin is a penicillin, and that is a time-dependent killing drug, meaning time above MIC is what makes this stuff work, right? So time above MIC is absolutely big. The half-life of amoxicillin is 1 hour, okay? 1 hour. That means that by 5 half-lives, that drug is gone, right? If you have normal renal function. So if you're giving something every 12 hours and basically it has a 5-hour or 1 hour half-life, and by after 5 half-lives it's gone, that means that for 7 out of 12 hours in your augmentin dosing, you have no drug around. None. Zip, zero, zilch. Okay? That's point one. Point two is that basically when you look at the data for BID amox-clav, it has only been studied in sinusitis and uncomplicated UTIs. Now, the FDA will not give sinusitis indications anymore because they recognize that for most sinusitis cases, jamming a cookie up your nose works as well as an antibiotic. Okay? So again, I think it's important to recognize that sinusitis, a lot of those indications came from times where the FDA did not require data and stringency that is anywhere near what they do now, and they won't give sinusitis indications anymore. That's one. Two, and I may have to talk with Dr. Pottinger about this after the talk, but for uncomplicated cystitis with a drug that dumps into the urine at huge concentrations, it would make sense that this might work even at BID dosing for uncomplicated cystitis. Those are the only two places this has been studied. I see our surgeons trying to use this all the time for gram-negatives and intra-abdominal infections, and that is not going to go well. The other thing, too, is look at what's recommended by the IDSA as well as the Europeans for community-acquired pneumonia. 1 gram of amoxicillin 3 times a day, okay? And remember for amox-clav, what's doing the heavy lifting? The amox, not the clav, right? Because the clav is there to protect the amox. And so 1 gram of amoxicillin 3 times a day is really kind of where you should be starting. And when you're using amox-clav, especially if it's for something other than sinusitis or UTI, it should probably be a minimum of 875 3 times a day if they have normal renal function. So again, dose really kind of matters here as you're kind of thinking about how to optimize a lot of what we use. Clicker problems again. Okay, and then this basically just kind of talks about what I was just telling you about the dose of amoxicillin that lives in the current community-acquired pneumonia guidelines. This is the dose of amoxicillin you're supposed to be giving. And also remember for kids, the dose is 90 milligrams per kilogram 90 milligrams per kilogram every day, right? That's a lot of amoxicillin when you translate that to adults. So this is the dose that I want you kind of thinking about when we talk about community-acquired pneumonia and community-acquired respiratory tract infections. Okay, and we talked about this already, so I won't dwell on this. This was basically the UTI and sinusitis stuff. And I absolutely loved Dr. Pottinger's point about what the IDSA says in 2019 about chasing odor of urines. I also want to know, is there anyone here who routinely sniffs urines? Because I've always wanted to know, because people are always like, the urine smells fine. I'm like, who does the sniffing on this? I'm like, because I've been looking for medical providers who will admit that they're the urine sniffers. I'm so far, and I'm not seeing any hands in here. So I want to know who these mysterious people are that report back that urine smells funny. So the other thing too, duration. Look at the right side of this slide. Okay, actually, let me change this up on you a little bit. First, look down the left side of this slide. Look at those indications, okay? Look at those indications for a minute. This is basically a ton of what you treat every day, especially if you're living in the outpatient setting. Now, I want you again to look at the right side of this slide that I've got in the blue box. Notice the addiction to 10, okay? I also want you to look at the reference in the bottom left corner of this slide. I am not giving you old data, all right? This is pretty darn up-to-date data. And really what I want to remind you of is the fact that look now at the middle column, guideline recommended duration of oral antibiotic therapy. See how we're still missing in this space? This is an area where, again, I think we're all still, and don't get me wrong, I'm just glad it's not 14 anymore. Because when I started doing these talks and when I started doing stewardship back before I had all this gray hair, this number would have been 14, easy, okay? So I think we've made progress, but again, I think we need to be continuing to do better. And remember, and again, look at this. They set us up for failure. Look in the middle of the slide, abscess, adult and pediatric under guideline recommended duration of oral antibiotic therapy. What do they say there? 5 to 10. If I see another bleeping range in a guideline, so help me, I'm going to light the guideline on fire and throw it out the window. I mean, pick a freaking number. Have any of you ever tried to enter a range for a duration of therapy in Epic? Anybody? I tell our fellows all the time. They're like, well, you know, I think we'll go 7 to 10 days. I'm like, yeah, you call the primary team and tell them you'll enter that order into Epic. I want to see you put 7 to 10 days in the range for the order for Epic. You can't do it. You gotta pick a duration. So guess what, guys? Pick short, right? Pick short, because as Dr. Pottinger said, and as I'm going to show you almost every single time we have looked at duration of therapy, short equals longer, with the exception of, wait for it, side effects from your antibiotic chemotherapy, all right? So again, there are downsides to this, and duration is absolutely key, and we need to be thinking about this. And I think Dr. Pottinger actually put this number up with 4% per day. Every day of antibiotics that you go longer, the data says, and this is a huge study that was published in Clinical Microbiology and Infection earlier this year, that basically for every day of antibiotics that you continue, the risk of adverse events goes up 4%. Okay, so and again, remember that antibiotics are the #1 cause of ER visits for drug-related adverse events. Usually they're rash. But again, C. diff, as we've already kind of talked about, is still a big challenge in this country. The other thing too is, I want to go to the worst of the worst, okay? Because what I've shown you so far is community-acquired pneumonia. What I've shown you so far is cellulitis. What I've shown you so far is some uncomplicated UTI. But what about the person with a gram-negative organism in their blood, okay? There's no question, are they sick? There's no question, is this a problem, right? Remember from your basic science, what happens if you inject gram-negatives directly into an animal? They get septic and die, right? So this is kind of the worst of the worst type scenarios that we're talking about here. And this is bacteremia with a gram-negative organism that is treated for 7 versus 14 days of therapy. And you can see that this was randomized, this was controlled, it was multiple center. This is everything that you want to see from a clinical trial. Now, the one thing I will say is notice that 90% of these were Enterobacteriaceae, so a lot of E. coli, because as Dr. Pottinger touched on, E. coli, E. coli, E. coli, E. coli from urinary tract, and pyelonephritis is where we get a lot of gram-negative bacteremias. So 90% of these organisms were Enterobacteriaceae. And what you see is that basically when they looked at their primary outcome, which was 90 days from randomization, these are the endpoints they looked at. Did people die? Was there clinical failure? Or did they get readmitted? So these are all very real-world endpoints that we would care about. And guess what they saw? They saw me not able to advance a slide. There we go. We saw absolutely no difference. Okay, there is abso-freaking-lutely no difference. And we've seen this now from pyelonephritis studies for over a decade. We've seen this now with all-comer gram-negative bacteremia. Now, again, this was driven primarily by urinary sources. But I think this shows you that even in things that we're super scared of, gram-negative organisms in people's blood, this really shows us that shorter durations of therapy are indeed adequate when they're compared to our more traditional durations of therapy. This, again, was a paper that was published earlier this year. And I think this is, in my opinion, the next big thing for antibiotic stewardship, especially on the inpatient side. You get admitted to a hospital, okay, for community-acquired pneumonia. You should get 5 days of antibiotics, not 10. 5, okay? You should get 5 days of antibiotics. You get ceftriaxone and azithromycin for 3 days, and you're better, and you're ready to go home. How many days of antibiotics should you go home with? Total duration of antibiotics should be 5 days, right? And if you're better, and you've gotten 3 days of ceftriaxone and azithromycin, you should not be going home with more than 2 days of antibiotics. I saw a hand over here that I love this gentleman's answer. He said 0. And this is not me doing Oregon Ducks because I'm a Coug and my daughter was a Beaver. And so doing this hurts my soul. So do not think this is Oregon Ducks, okay? This is 0, all right? So basically, you make a really good point there, and increasingly that's what the literature says, is that if they're good, if they've been afebrile, if they're stable, if they look much better, 3 days is fine. There's a lot of data out there that says 3 is probably fine for community-acquired pneumonia. If you go back to the original penicillin data, there's 1 day data, 1 for community-acquired pneumonia. Now, I'm not that crazy yet. I can get a little crazy on this stuff, but even I'm not that crazy yet. But I think 3 to 5, if they look great, so that person with community-acquired pneumonia with 3 days of ceftriaxone and azithromycin at most should go home with 2 more days of antibiotics. And again, you can see here that for 1 in 8 patients discharged from the hospital, they were going home with antibiotics, and 50% of those antibiotics were inappropriate. This number is actually considerably better than what the CDC had a couple years ago, where 70% of patients were going home with antibiotics, and almost all of it was excessive. So I think the numbers are a little bit better, but this is a space where we really, really need to get better. And I see my medicine teams do this all the time. It's like they're going home with something, and all of a sudden they reset the clock and send them home with another week of antibiotics. I'm like, what are you doing? No, stop it, okay? So this is, I think, really kind of the next space, and I think you're gonna see a lot of emphasis from Joint Commission on this because there's a lot of data in this space suggesting that this is a problem. And this was just, I wanted you to have a slide that you could look at and go, ha-ha, right? These are my durations. Those are the old school durations on the right side of the slide. The short duration, you can see right there. These are the durations that you should really be thinking about when it comes to the management of almost all of your kind of more routine infections that you see clinically. And again, basically nothing here is pushing past 7. So I think, if you leave here with one number in your head today, I would hope that you would leave with, if I'm going past 7 days on anything, I'm going to break out into a bit of a rash, and I need to think about whether or not I really need to go out to, no, right? There are very few scenarios where going out to 7, or especially past 7, is indicated anymore. So I think really we've gotten to 10, and 10's better than 14, but we've still got room to go, and see that a lot of these things, 5 and even 3 in some scenarios, are going to be increasingly where we're trying to push. So want to talk real briefly about diabetic foot infections in stewardship, because this is, again, a question that comes up a lot in this room every year. It's a question that comes up a lot for us on the ID consult service at OHSU all the time. And you know that we have a bit of a problem with diabetes in this country, and you can see that it is costing the U.S. a ton of money, and that really what we see a lot here is kind of round after round of antibiotics, and unfortunately we're using a lot of broad antibiotics. One of the things that I think is so important, okay, is to remember, how do antibiotics get to infected tissue? Blood flow, right? Blood flow. If you have a diabetic foot and it's ischemic and there's no blood flow to that foot, you can give antibiotics until the cows come home. It ain't going to revascularize that foot, okay? And so I think that is absolutely hugely important to remember. Antibiotics do not fix devascularized tissue. They do not regrow dead tissue. If you have dead bone in there, if you have necrotic skin and soft tissue in there, that's a surgical problem. That is not something antibiotics can fix for you. What can antibiotics fix for you? Skin and soft tissue infection, okay? And remember again that diabetic foot almost always starts as a skin and soft tissue infection. I see so many diabetic foot infections that basically people are on Pseudomonas coverage. No. Remember, okay, Pseudomonas in diabetic foot shows up late. I mean, we're talking, and you know it. You all know it. And I love the gentleman over there with the light green shirt on. He's got the Pseudomonas shirt rocking. He's wearing the right color. The color of the foot does not tell you that Pseudomonas is there. I've heard that from some of my surgical friends. No, not buying that. The other thing, too, is that 10 minutes, okay. So basically the thing to remember is Pseudomonas usually shows up in the foot where you walk into the building and you're like, diabetic foot, right? And you see, and I see some of you shaking your head. You people know that foot. You know that foot because it is these and that's the same thing with anaerobes. What do you think that smell is? How many of you did micro lab in medical school? Were you ever in there when they opened the anaerobe jars? It will it would just blow you backwards. How many of you with small children had a diaper genie? Ah, yes, right? The diaper genie, when it's been there too long and you open up the diaper genie, diabetic foot, anaerobes, right? That's the blast. And so really when you're talking about a foot infection that has gone that far down the road, that's when thinking about anaerobes and Pseudomonas makes sense. But again, remember, these start as skin and soft tissue infections. And what causes skin and soft tissue infections? Staphylococci and streptococci. Staphylococci and streptococci. The same stuff you learned in medical school. Just because it's in a shoe doesn't magically change what causes a skin and soft tissue infection, okay? So I think that's point one. Diabetic skin and soft tissue infections still start as staph and strep. Make sure you've got those covered, and you don't need to go super broad. That really, again, 1 to 2 weeks of this is more than adequate, but vascularization is key. You're not gonna fix anything if you don't have blood flow to that area. The other thing too is we get these gangrenous feet sometimes that show up, and basically we will have people try to leave folks on antibiotics to prevent sepsis. As far as I know, that data does not exist, and I have never seen a big old black necrotic foot cause overwhelming sepsis with some sort of badness, and that can be a conversation I also asked Dr. Pottinger about after this talk. But we see this sometimes where it's like, well, I'm preventing sepsis. That's pretty dicey. Treat the skin and soft tissue infection, get the surgical control. Long-term antibiotics in these people do really nothing but cause them to colonize with resistant stuff. So I think, these two slides, and I would really direct you to these two references that I've put on these slides. They are excellent references, both of which have been worked on by Ben Lipsky over in Seattle, who's done a ton of work in this space. So to wrap up, we're headed into respiratory season. The new COVID boosters have just shown up. Australia just had a bad flu season, okay? And Australia typically predicts what will happen in the Northern Hemisphere and in the US with our upcoming flu season. Flu has largely been gone for the last couple years. If any of you wanted proof that masks and distancing work for viral infections, check out the flu numbers. Right? What flu? Okay? So I think the big thing to remember is flu ain't gone. Okay? Flu will be back. We saw it in Australia again this year. We started to see it last year. Remember again that basically these vaccines are able to prevent multiple courses of antibiotics. And this is actually a statement from a paper that just came out looking specifically at pertussis vaccines. So not even viral vaccines, but look again at the number of cases worldwide. All of this would get treated with antibiotics, right? You treat pertussis with antibiotics. So think about what worldwide pertussis vaccination could do with regards to antibiotic use. Come on. This clicker absolutely does not like me. Okay, the other thing too, pneumococcal vaccination. There's been a major change this year to the pneumococcal vaccination recommendations. Basically what has happened is you've seen two new pneumococcal vaccines come to market. You've got Prevnar 20 that's basically replaced Prevnar 13, and then you've got a product from Merck that is a 15-valent that is designed to be given with PPSV 23 a year later. So you can either pick to go with the PCV 20 times 1, or you can do PCV 15 followed by PPSV 23 a year later, okay? Most folks, I think, are gonna go with the one and done just because it's easier, right? But the big thing is they've made it simpler. It's one and done. Okay, and they've changed the age recommendations again to basically have it for adults over 65. And really, this is a place we can do better. You can see that we are still not where we should be. I mean, especially look at that 19 to 64-year-old group with risk factors. Look how low that number is. So again, I think this is a space where we can be doing some good. And this is an antibiotic stewardship initiative, because look at what the third most common bacterial cause of third most common cause of identified community-acquired pneumonia is: Streptococcus pneumoniae. Right? So if you're able to prevent this with vaccine, you prevent antibiotic use. What about influenza? Data from the CDC basically says that for every 10% increase in vaccination, there is a 6.5% decrease in antibiotic use. All right, so making sure that we're using our influenza vaccines. Who's supposed to get influenza vaccine? If you are breathing, have a pulse, and are over 6 months of age, you are supposed to get an influenza vaccine, okay? So again, basically it's, my pharmacists are like, should we be giving this person an influenza, or do they have a pulse? Wait, hold on. Yep, if it moves, vaccinate it, click, okay? With influenza vaccines, that's pretty much where we are. Now the sub 6 month olds, those of you who have a 5-month-old, you know those things move. Those things move, right? They scream at you at 2 in the morning. They're very demanding. You can't vaccinate them quite yet. But once they hit 6 months, okay, over 6 months, we're again really making sure that we're using our influenza vaccines. And we know they're not perfect. One of you is going to say, but Jim, the influenza vaccines are not that good. They're a whole lot better than zero, okay? Whole lot better than zero. Even 50% effective is way better than zero. And again, I just showed you the data from the CDC that for every 10% increase in influenza vaccination, you decrease antibiotic use by roughly 7%. So again, a big, big win here. And again, I think, this is really another thing that I want to point out that we learned again from COVID. If you have someone with flu, especially if they've got any of these risk factors, okay? Remember, you've got drugs. Oseltamivir is out there. Baloxavir is out there. You have drugs that work for flu. And again, these are antivirals. They are not antibacterials. There's no need, if you have a positive flu, why are you giving an antibiotic for a virus? Use your antivirals, okay? And I think the thing that we have really learned very clearly from COVID that was always hinted at in the flu literature is get there early. Don't hum and haw. Don't wait around. If you've got a positive flu, and go, especially if they've got these symptoms. What did we learn from the COVID antivirals? What we thought early on was that the COVID antivirals, they don't work. They don't work. You know what? These drugs don't work. They just don't work. Why? Because we were getting them into people on day 9. As soon as we found out that if you got them into patients by day 3, by day 5, guess what? All of a sudden the drugs work. Okay, so getting these drugs into people, getting antivirals into people for both flu and COVID in a timely manner is absolutely key. So I think making sure that when you have those positive tests, remember that you can act on them. And again, this is data now that's about 4 years old, but it shows you how bad of a job we were doing, or probably are still doing, at using the antivirals available to us for influenza. Tamiflu is now generic, guys. It's not that expensive, and it's pretty darn well tolerated. So have a low threshold to use it, especially if you've got a positive flu in somebody who's at risk for flu complications. So to wrap this up, antibiotic stewardship, not going anywhere, right? You're seeing more and more requirements from the regulatory bodies that both inpatients and outpatients. All our CEO wants to talk about these days at our antibiotic stewardship meetings at OHSU is what are we doing for ambulatory stewardship? Ambulatory stewardship is the next big wave. We are still struggling with appropriate antibiotic use, and I think what COVID showed us is that diagnostic uncertainty is the enemy. When we don't know, unfortunately, we still prescribe antibiotics far too often. Remember that there are downsides to antibiotics almost always, and that less is more. If you catch yourself thinking about writing 10 days of antibiotics, no, stop it, okay, stop it, put it down, okay? I would say 5 for almost everything, 7 if you're nervous, okay, because I understand going from 10 to 7, I watch my ID fellows. My ID fellows, I'm like, you don't need 10 days, and they just kind of start to twitch, but they're doing better. We have group therapy, we talk it through, they're doing better. And again, on hospital discharge, please don't reset the clock. There's nothing magical about making sure they go home with another 7 days of antibiotics. It's total duration of antibiotic that you're targeting, not an inpatient duration followed by an outpatient duration, okay? Viral infections. Vaccines are stewardship tools. They consistently decrease antibiotic use across the board. Influenza, COVID, pneumococcal, these are all antibiotic stewardship tools that we really need to be using. And with that, I will thank Dr. Pottinger for saving me from having to use a lot of my slides. And I will open it up to any questions that you all have. And again, reiterate what a pleasure it is to be back with you all live this year. So any questions? All right. Oh, got a question in the back.
So you mentioned that anybody under 12 years old should likely get the Tamiflu?
Anybody under 12?
Anyone under 12?
Should get what?
Tamiflu, like when we have children, if they're under 12, we should probably get, and they're having symptoms, we should be giving them Tamiflu.
Oh, yeah. Okay. So basically for influenza, oseltamivir, basically if they have high risk for complications, which was on that list, on that slide that I showed you from the CDC, or they're hospitalized, abso-freaking-lutely, okay? Beyond that, I think it becomes a little bit more clinical judgment, but overall I agree with your statement. Yeah. So keep going.
So is there a risk like, of course, there's antibody resistance. Is there a risk of overusing the Tamiflu?
Yeah. I think, that is the concern. We've seen it obviously with COVID. We see it with influenza, that these viruses mutate. And it's really interesting that right before the 2009 H1N1 pandemic, there was this outbreak of oseltamivir resistant influenza that kind of disappeared and has never really reappeared. If you look at the CDC's surveillance data, better than 98% last year for the last few years of influenza viruses have been susceptible to oseltamivir. I think we should be using the drugs as recommended. We should be using them more than we are, but we certainly have to watch that data to make sure that we don't start to see resistance occur. Because I think as you put more out there, the likelihood that you're going to see more resistant virus pop up is obviously going to be there.
So in that chart, it was talking about like the high risk individuals is up to 60 months, so up to 12 years. If like school age children, if they are in a school environment, potential of spreading the flu, what should we be looking at?
Yeah, that's a really good question. So basically, I would not be using oseltamivir in school-age children to prevent outbreaks in schools. That's not consistent with current guidance or indications. I think the data is there for nursing homes. I think the data is probably there for institutions, for hospitals and whatnot, if you have an outbreak going on in the institution, because you have so many high-risk patients in one place. We know that complications of influenza occur in children, but that they're much less common, especially in school-age children. School-age children school-age children are basically vectors, but they don't get into trouble, and I would have concerns about putting it out there for prophylaxis, trying to prevent a school outbreak, because I think that, one, there's just no data doing that. And two, I think the likelihood that if you do that everywhere, you're going to see resistance emerge is probably a reasonable concern. So I would not be basically using those drugs in that setting to try to prevent an outbreak in a school.
Thank you.
Got a question over here.
Yeah, I have a question. Several years ago, spent several years on the Pharmacy and Therapeutics Committee at the hospital.
And you lived to tell about it, which is
know.
impressive.
We saw several studies that indicated time to initiation of antibiotic at the emergency room was correlated with mortality rates.
Yeah.
And so we put in protocols to try and speed up getting the antibiotic to the patient who needed it.
Yeah.
Because there was death data on that. Mm-hmm. How do we balance multiple studies with those indications with our antibiotic stewardship needs as well?
Sir, if I had the easy answer to that question, I would not be standing up here. I'd be out charging hundreds of thousands of dollars for consulting fees for U.S. healthcare institutions, because that is a wicked, wicked question, and a great question. I think the big thing when I think about that allows me to sleep a little bit better at night is one simple word: de-escalation, right? One of the things is I think that the sepsis bundles, because to your point, you have multiple data sets that show that if you delay effective antibiotic therapy, mortality goes up, right? The problem that we get into is that there's the same number of studies out there that show that antibiotics started in the ER don't get stopped. And I think that's the problem. I think you have to basically use your clinical judgment. You know, as Dr. Pottinger said so eloquently, you are the patient's physician, right? You have to use your clinical judgment. You have to use your training. If it doesn't pass the smell test, the patient looks septic, they meet the criteria for your sepsis bundle, hit them, right? Hit them with that first dose. What that first dose does is prevent what you're describing, mortality from delaying effective antibiotic therapy. But what can't happen, and what does happen far too often, is that antibiotic therapy is not reevaluated at 24 hours. Dr. Pottinger had a slide up, and it's something that we joke about on consult rounds every day. We start rounds a lot of times with, whose antibiotics are we stopping today? You know, because I think that's the key. We're really good at starting antibiotics. I think, you know, that's not the issue. I very rarely run across a provider where I'm like, you need to use broader spectrum antibiotics, or you need to start those antibiotics. That's not usually the problem. The problem is on day 2, when all of your cultures are negative, when you've got all of your results back, you've had time to kind of think about the patient, you've had time to learn more about the patient, and you're like, you know, this probably wasn't whatever, this was probably the bad meatloaf they ate, or, you know, whatever, right? But I mean, I think it's remembering to come back and turn those antibiotics off so that we're balancing the positives of early effective therapy against the risks of prolonged inappropriate therapy. Nobody faults you for the start in somebody who looks sick. The problem is when you've got an alternative diagnosis by day 3 and those antibiotics get continued out to day 7 or 9. Question right there. We have time for one more question, or?
This is a quick one. If you've had a PPSV 23,
Yeah.
should you get the Prevnar 20?
Yeah. So if all you've had is that PPSV 23, basically as long as it's been more than a year and you meet the Prevnar 20 criteria, you should get it at that point. Okay, and one of the things I would really encourage you to pull out that new pneumococcal guidance from CDC they've done, because it was so confusing. I mean, it was absolutely brutal. And they've really, I think, tried and largely succeeded in making the new recommendations much clearer. So yeah, I would really point you to that, but yes.
All right, I would take the advantage of asking the last question.
You own the microphone. You get to do things like that.
I really like the way you are saying, talk to patient about, say, antibiotics is a chemotherapy.
Yeah.
Because really, sometimes we are pressured by patient as well. They are saying, oh, why not 7 days, 10 days? And I have a question about, for some recurrent, for example, diabetes, food infection. Mm-hmm. And some patients just ask, you know, I'm obese. Why don't you give me a longer course? Why don't you give me a higher dose? Actually, higher dose is the one I have been asked quite a bit. Yeah,
I think that is a great question. And this is one of the real places where we need more and better data. Antibiotic dosing in the extremely obese is really kind of missing. We have a little bit of data, but not a ton. That being said, I think it's really important to remember that your beta-lactams, so your penicillins, your cephalosporins, have relatively low volumes of distribution, meaning that just because they're obese, you don't see hugely lower serum concentrations. So while I would dose high in those individuals, I wouldn't dose way outside your normal, is what I'm trying to say. So go to the top of kind of your safe range and go there, but I don't think, especially for beta-lactams, that you really need to push beyond that a lot of times. I have a lot of concerns with drugs like quinolones, clindamycins, tetracyclines, where the volumes of distribution are huge, and these drugs get out into tissues very well. But the problem is, you start to push doses on some of those drugs, you really get into tolerability problems. I'm a big fan of clindamycin 600 milligrams orally 3 times a day, but some patients aren't. you know, and that GI stuff can really get you into trouble. So I think that's the risk benefit that you're always trying to walk. And quinolones, yeesh. Trying to push the dose on the quinolones with that black box up there, yeesh. I mean, Dr. Pottinger was talking about documenting to keep yourself out of trouble. Yeah, you would definitely want to do that. So it is a really tough spot and an area where we need better data.
Very helpful. I can tell patients we're already up to the
Yeah,
highest.
I've pushed to the top.
Yes. Thank you so much. This is such a great lecture. Thank you.
Thank you very much.